and iris report on those patients we have operated with a pseudophakic version with the add-on lens. I will show you this implantation in a video. The plate haptic lens, you can implant it through 2.8 millimeters. It's the lens which is still not available right now because we are having a hydrophilic implant which is going nicely through 2.2 millimeters, and this implant is a hydrophobic one with the same magnification, and we have to implant it through 2.8 but without a suture. This is the surgery which takes place in topical anesthesia with a dilated pupil, and you can perform 2 side port incisions in order to fill up the anterior chamber and the area behind the iris with viscoelastic. We use Helon in these cases to take care for the endothelial cells. This is nothing we have financial interest in. This is just a regular setup as we use for any type of add-on lens implantation. So just viscoelastic is put in, then a clear cornea cut is made. This is a 2.5 millimeters knife, and I have to enlarge the incision up to 2.8. You can see the eye is still moving of the patient because it's topical anesthesia. Sometimes they have problems with fixating, but it's not necessary during the surgery. Take out the lens, you put it in the cartridge. You can take it with a tying forceps. This is what the lens looks like, and you can nicely place it into the cartridge and can implant it through an injector through 2.8 millimeters, and the new lens will be able to be injected through 2.2 millimeter, even wound assisted, which eases up procedure a little bit more. So cartridge is filled with viscoelastics. You can apply to the single-use injector, and then the lens is moved forward and directly implanted with the first leading haptic directly under the iris, and then I use some other instruments like an iris spatula or phaco spatula in order to pull the trailing haptics just under the iris, as you can see. Then I remove viscoelastic, and you see the lens does not decenter, it's just in front of the pseudophakic lens inside the eye. So just remove the viscoelastic and that's it. So, and these are the results over a follow-up period of 6 months' time of these 11 patients with a visual acuity coming from values of about, let's say, 20% and going up to a little bit more than 40% for the corrected distance visual acuity after 6 months. But distance is not so the matter of these lenses, but what we want to have is an increase in corrected near visual acuity. This is the spherical equivalent, and as you see in this setup, we ended up a little bit less than with a 3.0 diopters add. We are ending up at 2 and 2.5 diopters add, which is still sufficient for these cases, and it's stable over time. So looking at this table, I do not want to blame you with these results. I just picked out 2 of the cases, and you have a close look at the macula. When you see this patient suffering from a geographic atrophy, the photoreceptors are gone. In this 78-year-old female, visual acuity was quite less and no ability for reading even before lens implantation. This is the final refraction, what we have reached, and after 6 months visual acuity went up for distance and for near as well with a +3 diopters add. You see, in such severe cases we could not promise too much a rise in visual acuity, but over time there's still an adaptation. Even in this case, the adaptation process has taken place over 6 months. It's now 1 year follow-up, and it has increased a little bit more. So in another case with severe drusen, you can see it quite nice. Visual acuity was not so less even before implantation, but it went up 2 lines, and for near visual acuity the patient was with 25% of decimals not able to read without magnifying devices. Now he can read with a specular correction for a near add of +3, which is very convenient for this 88-year-old. So that we can conclude in this session that we have so far over half a year's time no intra or postoperative complications to declare, and the IOP values were stable and endothelial cells did not went down as the normal course did in these patients. We have seen in the pseudophakic eyes a little bit faster neuronal adaptation to the increased image, and visual rehabilitation sometimes takes a little longer. And this is what you have to tell your patients when you are using these magnifying devices, that they should not give up. And this is something very important. Even if the visual acuity for distance is not so good, you can enhance visual quality, and the contrast sensitivity you have to measure with the next study, which is still ongoing for these patients for bilateral implantation, which is recommended to avoid anisoconia in these patients. And therefore, I thank you very much for your kind attention.